Hi everyone, this is Cassie. The definition of the problem that I'm going to cover today is hospital physician shortage during the COVID-19 pandemic in New York. I'll be addressing to New York Mayor Blasio, and the organization that I am representing is the Healthcare Association of New York State, is the New York State Hospital Association. With New York being the epicenter of the national crisis, all options need to be on the table to make sure patients can get the care they need without possibly straining the physician who provide it. Since January, when first case appeared in Seattle, Washington state, there are total cases of 5.7 million, and the death records is close to 180,000. Hospital has pushed to limit as coronavirus cases rise. Physician workforce is challenged in pandemic already, and COVID-19 is just making it worse. On average, there are 2.6 physicians per thousand people in US. There are few according to Health System Tracker. There are fewer physicians per capita in the US than there are in most comparable countries, with United States ranking 26 out of 35 countries. Infections are striking the hospital staffs, reducing the numbers available to treat the sick. Here are the two evaluation criteria that I've been using. While we are trying to solve the shortage problem, we should not do so by also increasing extra workload to the frontline healthcare workers. The role of a helper should not change from caring to being cared, or be an increase in the death toll themselves. And the second criteria is effectiveness. How effective is the option in solving the physician shortage issue? Here is the option 1 that I am proposing. Stretch the workforce by recruiting physicians back from retirement. This is actually already being implemented in UK and Canada. They were assisted by a large slew of retired healthcare professionals. While we are considering adding those who have retired, other than internal medicine, we shouldn't skip other specialists such as mental health. In end of March, 76,000 healthcare workers who retired volunteered, and it breaks down to 8,000 physicians alone. With their experience, they can act as a consultant or supervise junior staff. And as of option 2, reach out to medical students and add them into the field. Offer competitive salary or reducing student loan payments for those who are willing to take a gap year and boost up the workforce. Very similar to option 1, this is actually being implemented in Australia already. New pay roles motivate final year medical students. On average, they work about 30 hours a week for between 3 and 6 months or even longer if needed. By doing this, not only it boosts hospital resources, but also help facilitating the clinical training that these medical students must undertake in order to graduate. Some medical universities, such as New York University, accelerate medical student trainings to fast track to graduate earlier. But even with these medical students who have already fulfilled the graduation requirements, with facing such a national crisis head-on, I, would they be ready mentally and physically right after graduate? And they may even need to go to the front lines. These are questions that we are still unknown and may cause potential issues. And the third option that I'm proposing is to lower the medical malpractice liability limit. Currently, New York does not have any restrictions on how much a person can recover in a medical malpractice lawsuit. New York is one of the only 15 states that do not have medical malpractice damage caps. By implementing option 3, it can prevent physicians from fleeing out of New York to states with lower malpractice liability limit, such as Texas. Just as comparison from past cases, birth injury damage in New York can be as high as 10 million versus Texas non-economic damage are capped at 2,500,000. And here's the Policy side-by-side table. We can see on the left are my 3 options and on the top are my 2 criteria. Older physicians will be at higher risk of becoming patients themselves. They are among the most susceptible to the disease. By recruiting them from retirement, the chance of serious infection is high, but they can act as a consultant or supervise junior staffs. And as medical students, they are young. They are less likely to get seriously ill even when infected, so the chance of serious infection are low. With boosting, with them adding, with medical students adding into the field, not only they can boost the hospital resources, but also facilitate their own clinical training. So in this criteria, it will be a win-win solution. Due to on average, United States physicians are medium age, so by lowering the medical malpractice liability limit, the chance for serious infections for them will be intermediate. As of my second criteria, effectiveness. Recruiting physicians back from retirement should be ready in a very effective time manner, as they should have less responsibility in their life. And for medical students, it really depends on the time of the recruitment, as they may need to adjust to the academic year, so most likely it's going to take them a while to be ready to start working. And as of the last option, it will be the slowest, as they need a while for other doctors to move and station into New York. With New York being in the epicenter of the national crisis, it has a total cases of 4,300,000 and death cases of 32,000, with fertility rate of 7%, which is way above national average. Even cases are dropping after May. There are still roughly 600 cases per day in New York. We've all learned from past painful experience. We need to better prepare in case of a second wave outbreak and before a vaccine becomes widely available. Mayor Bledsoe, we, as the Healthcare Association of New York State and healthcare professionals, urge you to take serious concern into the matter and pass the legislation that will allow medical students to work in our hospital in New York State and bolster their workforce. Thank you very much.